Welcome, everyone. I am Jeanne Nicholson, a former state senator and a former public health nurse. I'm going to start with a story. I was in the best trauma hospital with a fractured femur, waiting for my surgeons to schedule my surgery I needed when a woman came into my hospital room and told me I couldn't stay in the hospital. I needed to move with a fractured that hadn't been reduced to another hospital in another city during a major snowstorm. Well, it turns out my health insurance company didn't have a contract with the best trauma hospital in the metro area. So I was supposed to move not because I would get better care, but because the private commercial health insurance company would have to pay the hospital more money if I stayed at that hospital. I explained to the woman that I wasn't going anywhere until my fracture was repaired. It all seemed pretty deceptive to me for the insurance company to not point out to me that I couldn't go to the nearest hospital for care, but instead would have to go to the hospital that they selected, even if it wasn't in my best interest. They tell you what they will cover and which doctor you can go to, but the choice of hospitals is often in little tiny print in your plan and certainly isn't based on which hospital is closest to your home or best equipped to provide the best care considering your specific illness or injury. That leads up to the topic for tonight. We have two guests for tonight's webinar, and we will have an opportunity to ask them questions after each of them make their presentations. After their presentations, I'll show a short PowerPoint, and Kirby will share some ideas about relational organizing. We'll finish the evening with announcements about future webinars. And now it is my pleasure to introduce our two guests for tonight's webinar. The first guest is Rachel Madley. Rachel is a health
Oh,
policy leader with experience spanning Congress, federal agencies, advocacy organization, and grassroots movements, skilled in legislative strategy, coalition building, and public communications, with a strong track record of advancing healthcare system reforms, developing federal policy, and shaping public narratives. She brings unique scientific expertise to evidence-based policy making. She was on the staff for Pramila Jayapal. She has a PhD from Columbia University in New York City, and she is currently the executive director of Wendell Potter's organization, the Center for Health and Democracy. Please welcome Rachel Madley.
Thank you so much, everyone, and thank you for that great introduction. It is very exciting to be here with you all tonight. I see some familiar faces and some new faces, and really looking forward to digging into the deceptive practices and the practices that we see in the corporate health insurance industry. And so I have some slides that I am going to share on my screen. All right. Is everyone seeing that?
Yes.
Perfect. So, as the topic for tonight, I'm going to talk about corporate health insurer practices and also what they mean for patients. And as Jeannie shared, a lot of times these practices that seem very opaque and are decided in boardrooms and in shareholder calls are having huge effects on patients. And we need to understand the corporate practices in order to make things better for patients. So, As Jeannie mentioned, at the Center for Health and Democracy, we have been led by Wendell Potter. And Wendell Potter, as many of you probably know, was a former health insurance executive. He was the vice president for corporate communications at Cigna for years and Humana before that. And so he has a deep understanding of how to read earnings reports and documents put out by health insurance companies to understand what they're actually doing. So part of what we do at Center for Health and Democracy is we translate all of that. So our biggest findings from earnings reports, which the last annual earnings reports that were out were from 2025, are that the seven biggest health insurance conglomerates, so that is United, CVS, Aetna, Elevance, Anthem, Humana, Cigna, Centene, and Molina, they collected almost $1.7 trillion in revenue. Now, that is $175 billion more than in 2024. They made more than $54 billion in profits. Here's the point that I want folks to really hone in on. They did this while covering 10 million fewer people than they did in 2024. And I think that's a really important piece here because it's not that they're increasing their business and they're doing such a good job providing care to people that everyone's like, I want their insurance, and they're just getting more business that way. We're going to dig into how they are making more money even while they cover fewer people. And as we all know, it is going to get even worse as the years go on because of the expiration of the enhanced ACA premium tax credits and the cuts that were made in HR 1. So I'm going to dig into how they did this. But first, before we get into how they did it, I wanted to paint a picture of how they're using those profits, which come from the premium dollars that us as patients are paying them for medical care. And they also come from taxpayer dollars because many of these health insurance companies also administer programs like Medicare Advantage, which is the private plans within Medicare. They also administer a lot of Medicaid programs for states. So with our taxpayer dollars and our premium dollars, they have spent over 137 billion buying back their own stock since 2015. Now, what that means is they take money and then they repurchase shares of their stock to drive the value up to make their company worth more. Now, this is money that they could do a lot of different things with, such as reinvesting it into care, into lowering costs for patients, things like that. So this is, I'll send the slides around so you can really zoom in on this. It's from our newsletter, Healthcare Uncovered, but it shows all of the different seven companies and how much they spend on stock buybacks every single year. And then you have a total at the bottom. So I will make sure that you can really zoom in on that. You can figure out how much your health insurance company is spending. And again, this is just the big seven. There's a lot more companies that are doing things like this. So I wanted to use United Health Group as a case study of a lot of these practices. Now, this is simply because United Health Group is the biggest. It is not because they are the only ones doing this. Health insurance conglomerates are likely and mostly running the same playbooks, but at the Center for Health and Democracy, we looked at United Health Group with a big microscope to see what was going on there. So we found that United Health Group is actually much more than a health insurance company. Now, this is important because it's how they are able to make so much money, and it is how they are able to pull off a lot of the deceptive practices that they do. This is just a picture of our website where we actually put the names and tax ID numbers of all 2,700 subsidiaries of United Health Group. This was as of the end of 2024. They now have over 3,000 subsidiaries. Now, it's really important to understand that, again, United's not just a health insurance company, and it is actually mainly a clinical company now. So, over 2,000 of the subsidiaries within United Health Group are clinical entities. Other entities are pharmacies, pharmacy benefit managers. They have about 24 different pharmacy benefit managers. They have a few retail pharmacies, a few specialty pharmacies, and we're going to get into the deceptive practices there as well. They also have some other companies and even some international companies that I'll dig into a little bit. So their clinical entities are typically under the name Optum. So if you see Optum, if you go to a medical practice that has Optum in the name, it is part of United Health Group. United now owns or has close contractual ties with 1 in 10 doctors in the US through these Optum subsidiaries. Of course, there's the insurance companies. So United Healthcare are the insurance companies. Roughly 50 million people are on a United Healthcare plan, more than any other insurance company. And also, it's really important, as I mentioned before, these companies are getting a lot of taxpayer dollars. So 75% of United Healthcare's revenue in 2024 was from government subsidies. That's from Medicare Advantage plans, Medicaid plans. They also administer the Veterans Affairs Community Care Program, and that is a whole web of deceptive practices that I could talk about for a long time. I'll talk a little bit about it here, but just remember that most of this money that they're using to make profits is coming from taxpayer dollars. Again, they also have pharmacies. These are called Optum RX. That is their pharmacy benefit managers. And then they also have the brick and mortar pharmacies. And then they have a whole host of other different entities. Now, to really get at the deceptive practices, I'm going to take you on what I call a patient's journey through United Healthcare and or United Health Group, and I'm going to explain the deceptive practices at each step. So, when you start your care journey, typically you need to find a doctor, and many of us will use online tools to look for doctors in our area. Now, I know from experience when you look for endocrinologist in my area, one of the first things that will come up is Health Grades. It is a website that is essentially the Yelp for doctors. So you'll go on there, it'll tell you the doctor, the specialty, it gives ratings and what insurance they take. From looking at the website, you cannot tell, however, this website is owned by a subsidiary of United Health Group. So even when you think you're picking a doctor independently, they actually own the website that you're using to choose your doctor. Now, we do think it'll be really interesting. We haven't done this research yet, but to look at if there's a difference in the ratings of Optum physicians and non-Optum physicians on the website. So next, when you visit the doctor, you again have a 1 in 10 chance that you are going to be seeing a doctor that is employed by United Health Group or has close contractual ties. Again, sometimes the clinic is called Optum, sometimes it's not. So I have pictures of two here that have different names, American Health Network. So again, when you think you're choosing a doctor, it's likely that it's part of the United Health Group conglomerate. Step three, let's say your doctor suggested a treatment that you need, or a test, or a procedure. Again, a lot of folks turn to the internet to gather more information for better or for worse. I know as a parent, my toddler was prescribed ear tubes and ear tube surgery, and so I wanted to learn more about it. Looked it up, and actually Healthline was the first thing that came up. I read all about the procedure, what to expect, etc. I did that before we did this report. And what you can't tell from that website, similar to Health Grades, is that this is owned and operated by a subsidiary of United Health Group. So again, you're getting that influence, and you may not notice it, but United Health Group is having an influence on your choice of treatment, your choice of procedure. So it's pretty scary to think about. So next, when you want to get treatment or at least try to, United Health Group is very involved in that as well. Now, again, this is for every insurer, right? So whether you have United Healthcare, you could substitute Aetna, you can substitute Humana, Cigna. This is happening across the board. This is where a lot of the deceptive practices come in, and so I'm going to spend some time here. So many people have heard of prior authorization. It is when Even if your doctor prescribes a treatment, your health insurance company says, whoa, whoa, we need to review this and see if we think it's medically necessary for you. Unfortunately, although there are laws against the corporate practice of medicine, there are loopholes. And so health insurers often are able to exert a power over the care that you get. I actually went through this personally recently. I'm a type 1 diabetic, and so I was trying to refill my insulin prescription, and my insurance said, well,
Oh.
that's not on our formulary, and so we think you should switch to a different type of insulin. My doctor had to submit two different prior authorizations. We finally got it approved, but again, it's very strange, and I think we should start to really, really keep calling out that it is strange that your insurance company is telling you what medication they prefer you take, not your provider, not you, in conjunction with your physician, your health insurance company. Now, prior authorization has gotten more and more deceptive as time has gone on and as AI and technology have evolved. And that's why I have here the logo for Navi Health. Now, Navi Health is a healthcare sub or technology subsidiary of United Healthcare, and it uses algorithms to it's supposed to speed up prior authorizations and use AI to review them to approve them faster. What really happens is there are many, many, many wrongful denials, so much so that there have been a lot of reports from committees in Congress that, especially in cases of skilled nursing facilities and a lot of services that Medicaid users need or Medicare users need, um, the denial rates can be, 70, 80%. But when you appeal a denial, the appeal is often overturned at a rate of about 95%. So again, prior authorization is one of those deceptive practices where if you take one thing away from tonight, always appeal your prior authorization because often it's an inappropriate denial, and if you appeal it, it will get overturned. The health insurance companies are banking on the fact that people are not going to appeal the denial. And so, again, that's a deceptive practice where they're able to get out of paying for the care that you need. Next, like I said, I wanted to talk a little bit about prescriptions, about the pharmacy benefit managers and the pharmacies. So, this is another deceptive practice that has been getting a lot of attention from state legislatures and from Congress, which is very, very encouraging. So, health insurance companies have started what are called pharmacy benefit managers. They are essentially middlemen who claim to negotiate lower prices for drugs and manage the prescription drug benefits of your insurance plan. Now, what they really do is, unfortunately, they have crafted a scheme of either rebates, in which they pay a high price to drug manufacturers, then the drug manufacturers send a rebate back to the pharmacy benefit manager. But unfortunately, that rebate never makes it to the patient, so that's money in the PBM's pocket. There's also a model called spread pricing. That is where the PBM pays the drug manufacturer less than they reimburse the pharmacy for the drug. And then again, they pocket the spread. Now, there have been laws and efforts to make sure that rebates and things like that pass through to the patients. It is very, very tough to make sure that that actually happens when for-profit pharmacy benefit managers are in the game because the reason they are there is to make money, is to scrape money off the top. And so when lawmakers say spread pricing is no longer allowed, they come up with a different business model. They've also introduced GPOs, which are global purchasing organizations, which are essentially a middleman to the middleman. They're related to the PBMs. And so anything that's prohibited through the PBMs can now be done through the GPOs, and then the GPOs pass along the drug to the PBM. So very, very complex, and frankly, there is very little way to avoid this happening short of removing the profit motive from healthcare and from these pharmacy benefit transactions. Another deceptive practice that insurers and pharmacy benefit managers often use is steering you to certain pharmacies. So, for example, OptumRx may say, you're approved for this prescription, but you have to fill it at one of our specialty pharmacies. That provides a lot of issues, whether it is transportation, shipping, or you have a community pharmacy that you really trust that's easy to get to, and you would rather use that, but your insurance company and your pharmacy benefit manager say no. Now, the reason they do that is, again, another deceptive practice. I'm going to dig into that at the end, but it has to do with them avoiding certain regulations to keep more of your premium dollars as profit. And again, this is not just Optum, right? So CVS and Aetna, they have a conglomerate in which Aetna is the health insurer, Caremark is the pharmacy benefit manager, and then, of course, we all know that CVS has thousands of retail pharmacies across the country, as well as specialty pharmacies. So, nursing homes, United Health Group, and I will say Humana has a little bit got involved in nursing homes, but not much. But again, United Health Group is involved with nursing homes. They own them. This these deceptive practices here were revealed by the Guardian, and then United Health Group actually took the Guardian to court to stop the second article from coming out, as I understand it, and the Guardian just won that case. But what the Guardian found was that United Healthcare sends employees to nursing homes where they counsel people who have United Healthcare Medicare Advantage plans on end of life care. And they found that they often push for those United Healthcare enrollees to switch to a do not resuscitate order, which means if they were to stop breathing, they would not, no effort would be made to resuscitate them. Now, this is very, very cruel in my opinion, because the reason they want that DNR is because it's a lower medical cost. They don't have to transfer them to hospitals. And also, they found that the United Healthcare nurses in these nursing homes often delayed or deferred transferring patients who are showing stroke signs from the nursing home to the hospital, again, because they're trying to lower costs and doing it in a really deceptive way. Home care is another place where United Health Group is very involved. So these are two names of home care subsidiaries that are actually owned by United Health Group. And again, from the names, almost family personal care, you can't really tell who owns it and who's really controlling what's going on there. I said I would mention veterans benefits, and if you have any questions about this, I'm more than happy to go a little bit longer on this. But basically, United Health Group has a subsidiary called Optum Serve. Optum Serve administers the VA's community care program, so the program that allows veterans to get care outside of the VA. There has been a lot of evidence that Optum Serve is overbilling and double billing the United States government to the effect of tens of billions of dollars. And at the same time, United Healthcare sells what they call Patriot plans. They're these Medicare Advantage plans that they're advertised as being perfect for veterans. What they don't tell you is that many veterans who are in Medicare Advantage plans gets the bulk of their care at the VA. But since they're enrolled in the Medicare Advantage plan, United Healthcare still gets the full payment from the government to them for the care for that enrollee. So they're essentially double dipping from the government for the care for that veteran. And they're deceptively advertising to veterans that we have the plan for you. This is the Patriot plan. And finally, many folks probably heard about the Change Healthcare data breach a few years ago. Change Healthcare is now a subsidiary of United Health Group, and this really just shows that even if you try to avoid these healthcare conglomerates, use a small community health plan, use independent providers. Um, the healthcare system is such that providers cannot operate without using some sort of data warehouse like this. So Change Healthcare helps the payments get from the insurers to the providers, but all of our healthcare data is with them. And as we saw from the breach, it is vulnerable to attack. So want to talk about the last deceptive practice, and then I will um, pause for questions. So, a big question is why are all of these health insurers buying so many clinical entities? And the answer to that is the medical loss ratio. Now, you'll have to stick with me because this sounds very wonky, but it's really important. So, the medical loss ratio is a regulation that says health insurance companies have to spend at least 80 to 85% of the premium dollars that you and I pay them on our medical care. The goal was to increase transparency and quality in healthcare. Unfortunately, this led to health insurers buying up clinical entities because when they, as insurers, are paying money to a clinical entity, they get to report that as a medical cost for the purpose of the medical loss ratio. So rather than the money that they want to keep as profit being counted as that profit, which is limited to 15 to 20%, they can actually count it as medical claims, shift it over to the sister company, and then put it in their pocket as profit. We do see a lot of evidence of that happening, and I can get into that more if folks are interested during Q&A, but this is a real crux of what's going on here. The gaming of the medical loss ratio is a big problem, and a lot of patients don't realize that they are being steered by their insurer to a specific provider, to a specific pharmacy, not because that provider is the best for them, not because that pharmacy is the best or most convenient for them, but because it's owned by the insurer and it allows them to game the medical loss ratio. And so that was just, what I was talking about, the MLR under vertical integration, is just a very easy way for companies to game the system. All right. So I'm going to stop that and would be happy to take any questions.
My first question, Dr. Madley, is if we passed a piece of legislation in Colorado to create a single payer plan that is owned by the people in Colorado through an enterprise, and that the enterprise would pay for the care that a provider gives to a patient rather than a private commercial health insurance company. And if we pull down Medicaid and Medicare dollars to help cover that portion of the population, what happens when the patient needs to go get a prescription filled? Do they still go to a CVS and we are continuing to support a company that is not operating in our best interests? Do they still go to a private physician practice that is owned by United? And what can we do to prevent those kinds of ways of exploiting the quality of care for the people?
That's such a great question, and very exciting that you all are working on that in Colorado. In my graduate school days, worked a lot on the New York Health Act, which was the New York State single payer bill. Um, so if that were to pass, there are a few things that you could do. I think first, the single payer system would be beneficial for independent providers and community and independent pharmacies. And so I think you would see a a natural either stabilization of independent providers and pharmacies being able to stay open and potentially even an increase in those providers and pharmacies. Because right now, what the CVS's and the Uniteds of the world are doing is they're actually driving independent providers and independent pharmacies out of business. So if you are able to create a single payer system that treats all of those providers and all of those pharmacies the same way in terms of reimbursement, you will be able to tip the scales and really help those independent providers. In terms of patients still going to CVS, still going to an Optum provider, um, I think that is certainly doable. And it doesn't necessarily play into their deceptive practices as much because they cannot use most of their profiteering practices. If the single payer system sets the reimbursement fees, has no prior authorization, or as in some plans, just the prior authorization that exists in traditional Medicare, there is no way for them to use those deceptive practices. And so I actually think that it would kind of shut down the profiteering that they are doing for those patients who are in the single payer system. And so I think it would do great things on the provider side where they're owned by Optum, and it would also do really exciting things for the independent providers and pharmacies.
Thank you for that. Eileen, go ahead.
Sure. Yes, thank you for your excellent presentation. I have a question going back to the whole medical loss ratio with the vertical integration and these insurance companies owning provider practices. Is that something that Congress is currently looking into? I thought I heard something about that, or it sounds like something Elizabeth Warren would work on. So can you comment on that?
Yes, that is a great question. And there is a bill that the Center for Health and Democracy was very excited to see introduced. And it was introduced by Senator Elizabeth Warren and Senator Josh Hawley, who's a Republican from Missouri, I believe. And so it's a bipartisan issue, and you do see a lot of that really cropping up in Congress where there are folks on both sides of the aisle who recognize that this self-dealing is wrong. That bill is called the Break Up Big Medicine Act, and what it would do is essentially it would prohibit the cross ownership of health insurers, clinical practices, pharmacy benefit managers, pharmacies, and wholesale manufacturers, which are drug manufacturers. So it would really kind of get to the root problem,
Great, thanks.
of course.
All right, other questions for Dr. Madley?
Hi,
Yeah, go
this
ahead.
is actually Marcia Thorson.
Oh,
I,
Marcia.
yeah, sorry. Eric is my husband. Usually the computer he uses. I put my question in the chat, but on the MLR, where can people find out information? Is any of this public? Where can people get educated on this? I mean, I don't think providers really we have time to be doing this research, but even really know where to go. And certainly I don't think patients do. Is this public information? Where can we get educated?
That's a great question. So I do believe the medical loss ratios of health insurance plans are posted by CMS, the Centers for Medicare and Medicaid Services. Unfortunately, since there are thousands of different health insurance plan contracts and the data is posted at the contract level, it's very difficult to digest. Um, so Wendell publishes a newsletter called Healthcare Uncovered, and we do have a few articles that have really broken down the medical loss ratio. I will also say the way the regulation was written makes it a bit of a black box because not only are insurers allowed to count medical claims as things that are not profit, they're allowed to count quality improvement activities. That can be it's very broadly defined, unfortunately. We have article that shows that it's likely being gamed so that insurers make sure they meet the medical loss ratio. They just decide how much they need to spend on quality improvement. And I think especially for providers there, it begs the question, are insurers actually improving quality of care? Because that should really be happening at the provider level. And so why do we have that in the medical loss ratio anyway? Something we're pushing for at the center is to remove quality improvement from the medical loss ratio. So I know that was a long answer to your question. You can do some digging on CMS, but also we have some articles, and I'll put the links in the chat, that do a little bit of an explainer.
No, that's incredibly helpful. Thank you so much. Thank you for
Of
your work
course.
and your presentation.
Thanks.
Walter,
Hi, Jeannie. Thanks. And thanks, Rachel. And greetings from Montpelier, Vermont. Wendell and I are pretty good friends. I
That's
wanted
great.
to ask you, with all of that stuff you presented, we're sitting here as activists in Colorado and Vermont. We've got these health single payer systems, the School of Public Health and everything. How do we battle these united people? How do we, how do I guess say get at it is the right phrase I'm looking for. How? Because that's what we're going to have to do.
That's a really great question. And I think we are starting to see the work that so many folks on this call and across the country who have been in the single payer movement have been doing over the decades. We are seeing it break through. And I think one of the most important parts is storytelling. I know you've probably heard that before, but even Jeannie sharing your story, um, it's so powerful because, as you can tell from my presentation, health policy is incredibly complex. And so when you can connect a personal story to something like this. For example, I talked about PBMs and pharmacies. Um, we wrote in our newsletter about a family who had to drive 6 hours to get a medication for their child because they had to go to a specific specialty pharmacy, even though they had a community pharmacy in their town. And so, anytime you can connect it and make it tangible, really helps lawmakers to understand. And I also think health insurers are getting so brazen in their deceptive practices that even members of Congress who typically have good health insurance plans are being hit by this. So there was a hearing in the Energy and Commerce Committee where Representative Greg Murphy, who's a Republican from North Carolina, shared a story that he was just battling with insurance for treatment for, I think it was a brain tumor, months and months and months and months. And he was very, very frustrated. And so I think storytelling is one key. I think the other key is, while we work towards single payer, to evaluate every policy with, I always look at it with three questions. So, for example, the bill that Eileen asked about, the Break Up Big Medicine Act, it's not single payer, it's not Medicare for all. However, I ask myself three questions. One, will it decrease the power of the health insurance or the pharmaceutical industry? Two, will it improve or expand access to care for patients? Three, will it get us closer to Medicare for all? And I believe that the Break Up Big Medicine Act satisfies all three. And so we need to be pushing for that to lay the foundation for Medicare for all. And so thinking strategically, because if we're able to pass the Break Up Big Medicine Act, immediately United, CVS, Cigna, they will lose a lot of their market capitalization, a lot of their power. And that's power and money they use to lobby against Medicare for all. And so, how can we strategically weaken these conglomerates to lay the foundation for Medicare for all? So, I would say storytelling and then thinking strategically on the policies that seem like smaller steps, but are really going to pave the way as we continue pushing for Medicare for all.
Long fight.
Yes.
and would you agree, Rachel, not only telling the story, but explaining the solution so people feel like it doesn't have to be this way?
Exactly. And thank you so much for bringing that up, because I do think, and I've done some focus groups with folks on Medicare for all before. Our system is so broken, but it's also all anyone has ever known. And so it does sound like you are trying to pull the wool over their eyes when you describe this system that we could have, because it is truly so foreign to people. And so I think making them understand exactly as you're talking about the solution. Um, I always look at other countries. I've heard mixed reviews. Sometimes it doesn't help people to think about other countries' systems, but I think it's important to keep in mind that this is the only system that people have known. And so if they are skeptical at first, that is normal. And so how do we make it tangible for them? So thank you for pointing that out, Jeannie.
All right, more questions or comments for Dr. Madley? All right, seeing none, thank you so much. Please stay on for the rest of the webinar if you would like to. You're certainly welcome to, but we also know you have little ones at home. It's hard for me to imagine all the things you've already accomplished because you're so young. And we're very impressed with you and your knowledge, and will to rely on you in the future, if we can, to get back to you with other questions that we have, because, this is a lot of technical information to take in. And I think that it's just reassuring to us to know that we have a very reliable resource. So thank you again for your presentation. And now I'm going to turn it over to Karen Zink. Karen Zink is someone I've known for a long time. She, like me, is a nurse, and is indeed a nurse practitioner, and has owned and operated a very successful clinic in Southwest Colorado, and has some very direct experience working to get reimbursed by the health insurance companies for the care that she provides. So, Karen, please go ahead.
Thank you, Senator Nicholson. And Dr. Madley, I think what we need here is a condensed version of your PowerPoint presentation and your solutions that we could all have in our pocket to pull out at a moment's notice when we're trying to educate other people. That was excellent. So I started Southwest Women's Health Associates in 1989 as a nurse practitioner. At that time, we needed a collaborative agreement with a physician in order to practice, but after 2010, advanced practice nurses in the state of Colorado have full practice authority after they meet certain criteria. So I have quite a bit of experience with billing health insurance companies. Our practice is an insurance-based practice. If I had had my way about 15 years ago, I would have gone to a direct care model, because it is so brutal to collect money from insurance companies. So the tricks that they play, we as nurse practitioners are usually excellent documenters. We're likely to be pretty on time with our care and our documentation. And I know Eileen is a physician's assistant, so she may have some of the same things to say if she were speaking. But at any rate, we will submit a clean electronic claim to an insurance company. And it takes a little while for the claim to be processed, even though there are timely filing laws. But at any rate, when our medical biller, which is essential for us, starts posting the payments that have come in for the claims that we made, she often finds that we have been underpaid. And so we have to point that out to the insurance company, and then they agree, we underpaid you, but you can only resubmit 7 claims a day. So it's tedious to resubmit the claims that were underpaid, for instance, or remarkably, even in an electronic system with a clean claim, the claim can be completely lost sometimes. This particular insurance company I have notes from one of our companies. Our IUD supply cost went up by about $30 from the vendor that we purchase IUDs from. So we got in touch with the insurance company and said, our supply cost for IUDs has gone up by $30. Will you compensate us for that? And they said, no, just flat no. We'll continue to pay what we agreed to pay you for your IUDs. We don't care if your supply costs have gone up by $30. So the other thing that trips us up is there are frequent introductions of new plans within a particular insurance company. So the new plan might not know if our practice, which provides women's primary care, is a primary care practice or a gynecology practice or a what. So we can fall through the crack, or we get on a specialty list and we're doing primary care, or we're on a primary care and they don't see us as women's health nurse practitioner specialists, which we are. And the insurance companies used to have regional representatives that providers or staff or medical billers could call and ask questions of. Well, that's all gone. There's no one to call anymore. There's no one to ask. And then part of it has gone to chatbot. So we're trying to resolve claims issues or coverage issues with chatbot, and it's really hard to speak to a person. And the impact that it's had on our practice, although it's successful, it's only successful because we have people who really want to work in a private practice environment and who are willing to take less pay than in a corporate environment. But the same insurance company that I'm talking about tonight has not renegotiated the contract with Southwest Women's Health for a decade. So we're being paid the same thing today that we were being paid 10 years ago. Supply costs have gone up, costs of operating a business have gone up, licensure dues, liability insurance, all of those things go up, and we're still being paid at the same rate we were paid 10 years ago by this particular company. The other trick, and this is where I have a criticism for Medicare, they have a convention where they deduct 15% from the payment to a physician's assistant or a nurse practitioner because we don't have an MD credential. And that it doesn't matter that we're providing the exact same service for our scope of practice. So if we're doing an annual health appraisal, that's the same quality as a person would receive anywhere. If we're treating a bladder infection, strep throat, so on and so forth, those are standard billing codes. And the distinction between nurse practitioner care and physician care with copious research is that the plan of care is usually adhered to by the patient a little bit more if they saw a nurse practitioner, and the patient is more satisfied with the interaction that they had with the provider. Other than that, research, and a lot of it has not found that nurse practitioners provide a lesser quality of care, but we're not getting paid equitably for the care that we do provide. I served on a mediation team in 1989 for the state of Colorado when we were looking at the Nurse Practice Act and full practice authority and prescriptive authority for advanced practice nurses. And at that time, it was thought that 30% of primary care was being provided by nurse practitioners. However, we don't see that because of a Medicare function called incident to billing. And incident to is how most of our services are billed, and the service is actually billed under a physician provider identification number unless the nurse practitioner owns and operates his or her own practice independently. So in big corporations where nurse practitioners are providing a lot of primary care and other services, even in specialty clinics, the billing is incident to billing. So with incident to, the entire amount can be collected, and it's another little scheme. The facility gets 15% more than if that care were provided in a private practice because it's billed under a physician provider identification number, and it looks like that physician provider provided all of the care. So the care of the nurse practitioner is actually hidden in the system and therefore undervalued. And it is difficult to deal with third-party fiscal intermediaries, or whatever we want to call the middleman between the insurance company and the practice that's billing. So that's a barrier to success. But those are just some supporting comments that I have from the practitioner standpoint. And I think it's worthwhile to understand that private healthcare practitioners are often treated very poorly by insurance companies, and that's one of the reasons that they can have the profits that they can have. And it's not just nurse practitioners in our community. The independent physician practices are having all of the same struggles. So I'm happy to answer questions, and I think Dr. Madley covered it really well. And thank you for inviting me, Kirby, and Senator Nicholson.
Thank you, Karen. Questions for Karen or comments? Oh, Maddie has a question. Go ahead, Maddie.
Yeah, sorry, it took me a while to figure out how to raise my hand again. Thank you, Karen. I really appreciate you and all the work you're doing on all fronts of this problem. Thank you for sharing the impact it's having on practitioners. And I would also mention the problems with moral injury. Unfortunately, healthcare practitioners are moral injury is defined as knowing what you need to do for your patients and being prevented from doing it. And it's across the board for all practitioners at all levels of the healthcare system. And it's due to the barriers that are being put up by the profiteers.
Thank you for that, Maddie. And I would add that it's demoralizing to healthcare clinicians, and it borders on abuse, really. Maybe it is abusive. And an NPR spot that I heard several weeks ago claimed that 600 and some physicians have left our country this year to go to the Canadian healthcare system. So we can talk all we want about the payer system, but if we don't have providers to provide the care, we're going to be in a heap of trouble there too.
Right. Kathy, go ahead.
Yeah, I recently had, like yesterday, I'm a licensed professional counselor, and I was billing Medicare, and I was trying to find out why my claim was denied. And let me tell you, I couldn't talk to a live person. They said, you have to go through our automated system. Well, that Medicare number has letters in it. And it took me probably 45 minutes, and I had to hang up a couple times because AI did not understand my the letter that I was saying in the client's Medicare number. And I was totally frustrated. And I still don't know when I did finally get a person, they said, well, sometimes the claims get dropped. And I'm like, what? And so I resubmitted the claim twice, and we'll see what happens. But I don't know if anybody else has messed with AI, but this also affects mental health practitioners as well. I have a private practice. So I just thank you for letting me share my frustrations.
Well, I think that's the exact point that Dr. Madley was making at the beginning of the presentation when she said we need to share stories. It's not only stories about patients that are mistreated because of the way we finance healthcare. It's the way our providers are being mistreated. So absolutely, Kathy, that's totally appropriate to share your story. Maddie, go ahead.
Yeah, a couple things. First of all, yes, providers are abused by their corporate overlords. And the other thing from what you're saying, Kathy, is, everyone says our healthcare system is broken. And I think that that's a misunderstanding. It's actually working exactly how it was designed, which is to maximize profits. And the way they do that is to deny care and rip people off. So, I think that's a very important thing for people to understand. And the advantage of a single payer thing is that hopefully the purpose is what we'd expect, which is to maximize the health of the population and to be able to do that effectively. And by doing that, they save money and treat people and have better health outcomes.
All right. Wayne Caswell, please go ahead.
One of the things that I've also heard this evening is how incredibly complex our system is. But that too is intentional.
Yes.
Those laws were put in place to make it complex. And on Modern Health Talk, I have a blog and I write about my perspectives of things. And getting rid of the complexity of our system versus the simplicity of a Medicare for all kind of system. Think of the people in the clinicians and the billing process that you go through and all the administrative staff that it takes to handle all those different insurance plans and everything that you're dealing with. And so there's been a lot of discussion about the savings of a Medicare for all plan. And the CBO made estimates, and the Conservative Heritage Foundation had made estimates of what the cost of a Medicare for all would be, then compared to what we have today. And those savings just simplify and just compared U.S. costs versus the average of rest of the world, and the fact that we spend twice as much, have worse outcomes, less longevity, and that sort of thing. It would seem that just being average, we could save $2.5 trillion a year. But that in itself is a marketing message that's hard for a lot of consumers, regular people, to grasp hold of. We don't understand billions, much less trillions. How much per family? And so you can look at health expenditures per capita. That OECD has statistics from the other countries around the world, and we spend currently $14,000 per person, which is twice what the average of others. So and think of it per family, that's a huge cost. Families could save $7,000 per member of the family per year. That is absolutely huge. But that's not why I raised my hand. I raised my hand because as a marketing person coming from IBM, I tended to look at other ways of justifying big mainframe computers. And oftentimes we could justify the new mainframe just on this maintenance cost of the old system. You're replacing the old system because the new one's so it's more reliable. So I put together an article recently, and I put the link to it in the chat. It is about Medicare for all downstream benefits. And so I look beyond the accounting, the savings that we would see from administrative costs, looking at things like increased workforce productivity. When people are healthier, and they're not having to take off time from work or take off time to care for an elderly patient or a sick kid, they're in the office more, and it affects their attention and their overall productivity. So that has a direct impact on income of the nation. That looks at things like job lock. moving away from employer-provided insurance to a Medicare for all system means that workers would have more flexibility to seek other opportunities. And the employers would not currently employers want to lock the worker in with their health insurance subsidies. But if they didn't have to, then they could afford to pay higher wages. So it could increase incomes, not only the savings per family, but how about incomes, or be able to pursue your dreams rather than being stuck in the dead job, or looking at different ways of measuring success, and then we talk about wellness, and I think, Karen, you were talking suggested if you were going in starting a practice again, you might do it more like a concierge clinic and bypass insurances altogether. I've heard of a lot of physicians that are starting to move towards functional medicine. Because, as Benjamin Franklin says, an ounce of prevention is worth a pound of cure. So that we with a Medicare for all system, if we have government funded health insurance, think of what it does for other policy decisions we might make, federal and state level. We might put things in place to emphasize the nutrition, exercise, sleep, stress management, things like that, the pillars of health that the physicians learn so little about in medical school.
Karen, go ahead.
I just wanted to make a comment on the distinction between concierge care and direct primary care. So the term, if we're seeing primary care provider, is direct primary care. And I am shocked at the small amount of money that they can get by on getting a monthly payment. In Durango, children are seen for $22 a month. It goes by age. And Medicare age people are $120 a month or something like that. But they have a pharmacy on site, generic drugs, EKG. It's spectacular care. And I think if we looked at a direct primary care model, we could see what the actual cost of care is. And again, it's surprising how little they can make and still be satisfied with or charge, I should say, how little they can charge and still be satisfied with the practice.
Yeah, because they're getting rid of all that unnecessary administrative cost that all of us are paying for now. Exactly. And I'm going to quickly share my PowerPoint presentation with you. So our message to all of you is that it doesn't have to be this way. We don't have to have the system that we have right now. We can have a very different system. There is a solution. And see if I can get my slides to advance here. So our plan is to have universal health care for Colorado now. Our goal is to provide high quality, comprehensive health care for all Colorado residents that each can afford. Throughout 2026, our plan is to educate voters about the problems with our current financing methods and help them envision better ways to pay for health care. If the Colorado School of Public Health determines that a universal health care plan is financially feasible when they complete their analysis in December, late December, December 31st of this year, we plan to educate voters and elected officials about the results of the Colorado School of Public Health analysis in early 2027. And I want to point out, to your point, Mr. Caswell, that is an analysis that will, I think, be something you particularly want to look at, because it will be data that is very specific to individuals. Instead of talking about how we save money overall in the state, it would be how we will save money as individual families and individual patients. And we know that that will be more meaningful to Colorado consumers than telling them the billions of dollars that we will save. We also plan to poll Colorado voters to learn their views on financing healthcare using a nonprofit, publicly funded, privately delivered healthcare plan, and win the support of at least 1.9 million plus one, 50% plus one of the voters about the benefits of one nonprofit, publicly funded, privately delivered health insurance plan for all Colorado residents. We need to and are planning to educate city councils, school boards, and county commissioners and encourage them to pass resolutions in support of our plan. And we need to continue to build a strong coalition of Colorado organizations and individuals supporting universal health care. We need to raise at least $15 million for professional polling, campaign manager, fundraiser, field organizer, marketing experts, and legal counsel. And we need to support national legislation to remove barriers to a state-based, nonprofit, publicly funded, privately delivered healthcare plan. After we accomplish all that, we need to create a transition team to be ready to implement the plan that we pass through a successful ballot measure. We will pass a ballot measure to publicly finance a healthcare plan for all Colorado residents, we hope, in 2028, November of 2028. And to do all this, we need all hands on deck. Here's how you can help. You can volunteer. You can volunteer 1 hour a year, and you'll be doing more. You can volunteer a couple of hours a year to staff a booth at your county fair. You can write a letter to the editor for your local paper. You can invite your neighbors and show a documentary at your local library or in your home. You can carry a banner in your local parade. You can be a guest on your local radio talk show. You can join the Speakers Bureau and talk to your local Rotary Club. And you can donate. You can donate through the Colorado Foundation for Universal Healthcare, or you can donate through fixhealthcarenowcolorado.org. You can donate when you shop at King Soopers, and all your contributions are appreciated. As Jane Goodall said, we can all make a difference. Thank you, everyone. We appreciate all of you and appreciate your willingness to volunteer and keep up the momentum so that we can pass a measure in Colorado to have single-payer health care and show the rest of the country how this is done. Have a wonderful evening.
Thanks, Jeannie. Thanks, Karen.
Thank you. Thank you.